I would like to introduce our first speaker. Dr. Joseph G. Allen is an associate professor at the Harvard Chan School of Public Health and the director of Harvard's Healthy Buildings program. He is a co-author of Healthy Buildings, How Indoor Spaces Can Make You Sick or Keep You Well. During the COVID-19 pandemic, he served as the commissioner of the Lancet COVID-19 Commission and chair of its Safe Work, Safe Schools, and Safe Travel Task Force. Dr. Allen is an editor for two journals, the Indoor Environments and Journal of Exposure, Science and Environmental Epidemiology, and has authored over 100 peer-reviewed scientific papers. Take it away, Dr. Allen.
All right, thanks so much. A really nice introduction. Great to be here with my colleagues. If I can ask the moderator to just bring up that prompt to let me share my screen, I can do that for you. It's a pleasure. I've worked a lot with the U.S. Green Building Council Center for Green Schools, so it's nice to be here with them and the Denver Public Schools and the Indoor Environments Division at the USCPA, which is just terrific. All right, terrific. Yeah, so I'm going to try and keep this interesting and bring in some of the research and what we know about healthy indoor environments for schools. It starts with good ventilation, filtration, and source control, as you just heard from the EPA. I want to talk about infectious disease transmission and really what's happening in every classroom, but also every indoor space, and some fundamental shifts that have occurred as a result of the pandemic, at least in terms of the public awareness about what's actually happening. This is a project I worked on with the New York Times to visualize what's happening in the classroom. As we all just sit around, breathe, talk, we're emitting respiratory aerosols. And as the figure shows, these tracer gases show that these respiratory particles from our lungs fill up a room much like cigarette smoke. They don't stop at some imaginary 6-foot buffer. They fill up the room. And I think once you see it, you can't unsee it. I think these kind of visuals really help to describe what's going on in the space. And it turns out, depending on the ventilation or filtration of the room, it could be as much as 1, 2, 3% or more of the air you're breathing in every space you're in just came out of the lungs of other people in that room. So we call the rebreathed fraction. So it makes sense. You want to try and minimize how much of that is occurring, especially if people are sick. We modeled this out to show what happens if someone's infected. In this case, we picked a student in the classroom emitting infectious respiratory aerosols, and very quickly you can see that the room fills up with infectious particles. You can see the overlay view over on the right here that the one person then fills up the room with enough, high enough concentrations to infect many people. In fact, this is how we have super spreading events where one person may infect 70, 80, 90% of the people in the room. It's easy to see how that can happen when you visualize it. Also important in the visualization is what happens when you take simple steps, like in this case, opening up a window. So the gradients change, the buildup of the smoke changes. You still have localized pockets, but already we see the reduced concentration. In this model, we then add a portable air cleaner with a HEPA filter in the back of the room, and the combination of ventilation and filtration dramatically reduce the concentrations in the room. Can transmission still happen? Yes, of course it can, but you're no longer creating the conditions where super spreading, where one person will infect people even at the far side of the room. So we've learned our lesson, I think, from the pandemic. Before the pandemic, there was a lot of argument about how respiratory viruses were spread, SARS-CoV-2, but also influenza and RSV and others. But it's become quite clear that the dominant mode of transmission is airborne transmission, and with nearly all transmission happening indoors. That's important because once we recognize that, we can determine what controls are necessary. The goal of good ventilation filtration is not just to prevent or limit the spread of infectious diseases. There's also the many positive benefits around human health and flourishing and thriving. What's showing on the screen is a set of studies we did looking at adults and their cognitive function and indoor air quality. It's a set of studies we call the Cog Effect studies. This is the first one. Basically, we enrolled a set of participants to spend time working in this office environment, and we changed the air in subtle ways from the floor below without them knowing. And we tested their cognitive function at the end of the day. It's a double-blind test. And the results are really quite dramatic. Controlling for other factors, we see that across 9 cognitive function domains, when we provide a better indoor environment, better ventilation, lower chemical load, we see people perform better on these tests of higher order cognitive function. How do they seek out and utilize information? How do they respond during a crisis? How do they orient themselves to different tasks? How focused can they be on the task at hand? So this is an interesting finding, but then the question is, does this hold outside of a laboratory? So 2 years ago or 3 years ago, we started a similar study. We actually looked to test people globally to see how indoor air quality impacted cognitive function. And sure enough, we see very similar results. And I've highlighted the blue box on the figure on the left. This figure shows the relationship between carbon dioxide, or CO2, which is a useful proxy for ventilation and an indicator of occupancy as well. And on the vertical axis, or the y-axis, is the cognitive function test called the Stroop test. Something really quite interesting here is that we see a linear response, meaning even at low levels of CO2, we see a benefit of better ventilation in terms of cognitive function now out in the real world. A new study of ours in the CogEffect series that just published maybe 2 weeks ago, we extended this to think about not just tests of cognitive function and addition, subtraction, but also the other half of the brain, the half of the brain that's focused on creativity. And sure enough, we find similar impacts. In these buildings with better ventilation, we see improved performance on tests of creativity, controlling for all of the factors. That starts to paint a picture about how indoor air quality is influencing our ability of our brain to function on these tests of higher order cognitive function, addition, subtraction, and also our ability to perform creatively. So of course, what does this mean for schools? Well, of course, there's many adults working in schools, but also it's totally consistent with the full body of science on how good schools and indoor air quality influence student health, student thinking, and student performance. For example, there are many studies now showing that kids in schools with better ventilation, better air quality perform better on test scores, math test scores, and reading test scores, and other tests of achievement. So we see this over and over in the literature. It's not surprising. We see similar results for adults and kids. In fact, we see it for kids of all ages, from the very youngest in schools all the way up to the very oldest in schools, and for adults as well. So we know that ventilation and filtration, indoor air quality matter a lot to adult and kid health, thinking, and overall performance. So the key question then becomes, well, what are the standards that we're trying to achieve in terms of good ventilation and filtration? And this is an area that is starting to change and finally getting the attention it deserves. This is a piece I wrote in the American Journal of Public Health in August, looking at the history of ventilation, but as told through the lens of public health. And the short story is this: over 150 years ago, Florence Nightingale told us that the only defense a true nurse either asks or needs is fresh air from an open window. Right about that time, there was a physician scientist named John Shaw Billings in 1893 who set the first health-based ventilation target of 30 CFM per person, 30 cubic feet per minute per person. In 1895, Ashby, the precursor to ASHRAE, adopted this health-based target of 30 CFM per person. In 1925, 22 states in the US adopted this health-based ventilation target. However, in the 1970s, ASHRAE developed the standard for acceptable indoor air quality, where they lowered the ventilation rate by half or more. We moved from a health-based ventilation target to a target that was set largely to mitigate and control odors from humans. So we went from a health-based standard to an odor control standard. The standard for acceptable indoor air quality is objectively not acceptable. It's not a health-based standard, but ultimately that's guided a lot of the decisions around ventilation in schools and offices and everywhere else we spend our time. So the question that came up during the pandemic, I think we correctly called it early on in the pandemic, buildings would play a key role in mitigating spread. We needed to increase ventilation, improve filtration, but a question no one seemed to want to answer was, well, how much? What is that target? We had a standard for acceptable minimums that was unacceptable. We had targets from 100 years ago, the pandemic hits, and there was very little out there in terms of the specific guidance. Along with Shelley Miller at University of Colorado Boulder, we put out some guidance early in the pandemic on schools. We recommended that schools target 4 to 6 air changes per hour. This is in line with the ventilation targets that ASHRAE had published, but for healthcare. We published this in JAMA a few months after we released it for schools. But there's only a handful of guidance out there during the pandemic on these health-based or elevated ventilation targets. During the pandemic, I was a commissioner on the Lancet COVID-19 Commission. I chaired their task force on safe work, safe school, and safe travel. I worked with wonderful colleagues all around the world. And we all agreed that the current ventilation targets are too low. Everyone agreed that the ASHRAE standard for acceptable ventilation was too low. And there would be major public health gains for increasing the ventilation rate targets. There was general consensus around what those targets were, despite good scientific debate around which metric and what exact number. But there was urgency to move this conversation forward. We wrote a report proposing these higher ventilation rates to combat airborne respiratory infectious diseases. We used several different metrics. We provided the data in a good, better, or best format. And you'll see some at least one familiar number here, that 30 CFM per person. We didn't invent this. This is over 100 years old. That was first set as a health-based target. All of the literature since then has supported this as a target. This number appears in my book, written before the pandemic, came out right during the pandemic, 30 CFM per person as a health-based ventilation target. This isn't a mystery. All the science points to this as a good target, certainly well above the floor or not unacceptable, acceptable minimums. We worked with the White House and had the first ever summit on indoor air quality, where we presented this work from the Lancet COVID-19 Commission. The White House used this to work with ASHRAE, who several weeks after that agreed to develop their first ever truly health-based ventilation standard. The White House also worked with CDC, and just a few months later, CDC adopted some of this work from the Lancet COVID-19 Commission and others, and they put out their first health-based ventilation target of 5 or more air changes per hour. They chose an air change per hour metric. Some have chosen the volumetric flow per person metric of the 30 CFM per person. You can see in the red bubble I've highlighted here how we thought about it on the Lancet Commission, 4 to 6 air changes or 20 to 30 plus CFM per person. There's been a coalescing or an agreement happening with scientists all across the world. This is an article written by 40 of us, or 40 or more of us, published in Science, where you see the recommendation here. We recommended 30 CFM per person as a target for a health-based outdoor air ventilation target. So you can kind of see where we're going. We're actually returning to our roots from 100 years ago, getting back towards designing and operating our buildings for health. We had a really nice win just a couple months ago. The California Department of Public Health adopted the Healthy Building Recommendations for California schools. And you'll see here in the note, they followed and adopted what was also put forward by Lancet COVID-19 Commission. California Department of Public Health recommends for schools a minimum of at least 5 air changes per hour or 30 CFM per occupant per person, whichever is greater. Last thought, I'm going to pass it right back. This is a moment in time. Pandemics change societies in a million ways. One of the key lessons from the pandemic is we learned and got the message across that, one, indoor air quality matters for a lot of reasons: infectious disease, cognitive function, student performance, student well-being, and health. And two, we know that existing standards are simply too low. They're not evidence-based, they're not based on health, and they haven't been for a long time. It is time to recommit to ventilation, not as a technical standard for minimally acceptable conditions, but as a cornerstone of public health. Thank you.
Wow, thank you so much, Dr. Allen, for sharing the latest research on making the health case for indoor air quality management in schools, addressing adequate ventilation to manage airborne infection